white shadow on your x-ray. We will try to do something with it. I will start with a bit of my last talk, which would be like more of the hypoplasia of the lungs, and then we'll continue trying to see how we can address heart disease on chest x-ray. So I don't have any conflict of interest. So we have a kid, it's like a 12-year-old, which has asymmetrical auscultation with the regular checkup with this doctor. So the doctor ordered an x-ray. So what do we see? So you see that the mediastinum is shifted on the right. You see that your right diaphragm is up, and you see that the right lung is super small. And then here you see that, I don't know, that line, which tells us that there's probably an hypoplasia of the right lung. And you see that the left lung is trying to compensate for the right one. So here you see that the diaphragm is up, and then you see here that the trachea is on the right. And if you try yourself, you see that line here, which was a big vein. So it's a scimitar syndrome and associated with a lung hypoplasia. So what's a scimitar syndrome? A scimitar syndrome is basically an hypoplasia of the lung with a small pulmonary artery and an arterial vascular supply and from the systemic circulation, and a vein coming out to the systemic circulation. So here you have another example of a less hypoplastic lung, but you see more the vein, so it's the abnormal drainage vein that goes into the IVC, into the IVC, so you have a small lung, an anomalous aorta, artery from the aorta, and an anomalous vein to the inferior vena cava with the hypoplastic lung, and then compensation from the left lung, which would be hyperinflated. So here we have a pulmonary agenesis. It's a story that it's a bit weird, because in the prenatal ultrasound, we thought that there was a big mass on the left chest of the baby, pushing the heart on the right, with almost no lung be seen on the right. So it was a baby that was prepared for an exit procedure, and the gynecologist, the surgeon will, jump on the baby, and then when the baby was born, it was doing just fine. So finally, what was that? It was a complete agenesis of the right lung, which is rare, but I saw a couple of ones in my careers. So it's basically one of the lungs that didn't get there at all. So you have no bronchus, no pulmonary vein, no pulmonary artery. And here you see the MR, which you have the right, the heart, which is completely filling the right chest, and only one lung on the left. So here we have a kid that has been operated elsewhere, but you don't have any file. So what do we see? You see that the mediastinum is slightly shifted on the right. You see that the left lung looks normal, but the right lung is a bit hypertransparent. And you see that the diaphragm is a bit, let's say, irregular compared to the other one, and a bit upper. So this was the good lung, and this was the bad lung, let's say. So it was a patient that was already operated for a diaphragmatic hernia on the right, which is not the more common. But when you see asymmetrical lung, you have to check for yourself which one would be the good one and which one would be the not good one. So here we have an asymptomatic patient that's come from a chest x-ray for, I don't remember why. So what do we see here? So you see that the ribs are close to each other. There is a small scoliosis, And then you see that the mediastinum is shifted on the right, trachea is shifted on the right, and that the right lung is not big. You cannot see really well the diaphragm, but it's probably there. And here you see that the left lung is trying to take the place here of the right one, probably anteriorly. So what it is, it's a hypoplastic right lung, which we confirm on scan. There was no atelectasis. It was just a hypoplastic lung, which I don't remember. It would be 1 or 2 lobes only. So why can we have pulmonary hypoplasia? So you can have a congenital one with just 1 or 2 lobes, but you clearly can have pulmonary hypoplasia, like I show you with already known diaphragmatic hernia, patient with oligohydramnios or anamnios in the prenatal state that they cannot develop their lungs because there was not enough amniotic fluid. And you can have also unilateral absence of pulmonary artery. So you have only a lung that it's irrigated by artery supplies from the aorta, which is not good for the lung. So next, we will see how can we approach a congenital heart disease on plain film. So what do we look for? So it's the plain film is not the state-of-the-art evaluation of congenital heart disease, but sometimes you can have clues, or you can follow kids that are known elsewhere and you don't have any anterior imaging, or they're already known for heart disease and they come to the emergency room for a cough or fever, and then you get the x-ray. And sometimes you have kids that are not known for anything because they were not followed. They're from, I don't know, a place that they don't have a good health care. So sometimes they just come to us and we don't have any history. So it's good to know how to approach it. So you can look at the situs. It's not a final diagnosis, but we can see where the things are in the chest of the kid. So you can figure out the position of the great vessels. You can see the heart shape and the size of the heart, the mediastinum and its thymus, the lung vascularization. Is it increased? Is it decreased? Is it normal? What looks the pulmonary parenchyma, the bones, and never forget the old films, which are your best friends. Okay, so we have the case number 1, which is a little kid in the NICU, which there was a couple of weird things on his x-ray. So you see that the heart shape is a bit, let's say, atypical. And then you have the stomach bubble on the right. You have the apex on the left, and you probably have here the right aortic arch, which is not on the good side. And here we have another case of a kid that was already been operated. You see all those wires and pulmonary replacement. So you see that the apex is on the left. You see that the aortic arch is on the left, but the right, there's a right stomach. So the pulmonary bubble is on the right. Here we have another case. So the first thing to check when you have flip hearts is your right and left are well placed, because the first thing to check is your technologist, did she mixed up the right and left, and then it's just a kid that is normal, but the film is switched. So on that kid, the right was on the right and the left was on the left. So here you have a right pulmonary bubble. Here you have a heart that the apex is on the right. And then here, if you zoom, you see that the right pulmonary artery is on the left, and that the left pulmonary artery is on the right. So it's a complete situs inversus. So when we have the first step is our situs. It's not a definitive diagnosis, but it's a beginning of investigation. So your aortic knob, your apex of the heart, and your stomach should be all on the same side, on the left. So if they're all on the left, you can still have a cardiac congenital heart disease, but that step is normal for the X-ray. If everything's on the right, you look for an inversus like our last case. And if you have like different sides, like a stomach on the right, you look for a situs ambiguous. So here's an example of the tracheobronchial tree when you have those ambiguous situs. So here it's a case of left isomerism, which you have two left main bronchus. So a left main bronchus is a J-shaped with only two lobes, and it's hypoarterial because you have the pulmonary artery that crosses it. When you have a right isomerism, you have two bronchus of the right shaped. So you have a short bronchus with a rapid bifurcation, and they are epiarterial, not hypoarterial, because no pulmonary artery crosses the bronchus on the right side. So it's an example of a 3D which you have the trachea here and two bronchus that looks like left bronchus in a patient with congenital heterotraxia with left isomerism. Okay, so if you have a suspicion of ambiguous situs, what do you do next? You do the ultrasound, it's always, but you have to do an abdominal ultrasound to see, is there an IVC? Because you have associated with IVC interruption. Is there a spleen? On which side? How many spleen do you have? Where's the liver? Is it middle? Is it on the right? Is it on the left? Do you have a gallbladder? And the abdominal vessel, so the mesenteric artery situs, so where's the mesenteric vein and with the artery, mesenteric artery. So if they're not on the good side, you can check for a malrotation by an upper GI follow-through, because those kids are at risk of volvulus when they have a malrotation. Okay, so we check the situs and then we check the heart size. So everybody can see here that the heart is big. So do we have other clues? It's a huge heart from looks, every part of the heart is huge. You see that it's come really upper here. So it's more of a, in French we say a carafe. It's a, I don't know, it's a shape that goes really up. And if you see it closer, you see that you have a double shadow here. And here, I will zoom it for you. So here you have that hypo and hyper and hypo. So you see here that you have your Oreo cookie sign, which is a pericardial fat pad sign. So you have the pericardial fat fluid in the pericardial, and then you have again the fat pad, so we would call it, it's an Oreo cookie sign, let's say like 4 fillings, but it's a rare sign, but you can see it when you have a pericardial effusion. We have another kid here. So the pediatrician comes to us and tells us, okay, the baby is in respiratory distress, no cyanosis, but really hard time breathing, is 2 months old. Is it just a bronchiolitis, or is there any heart disease underlying that? So on that chest x-ray, what can we see? You see that the baby, the lungs are hyperinflated. You see that the heart is big, especially on the left side of the heart, not that much on the right side. And here you see the complete catalectasis of the left lower lungs with no pleural effusion. So if we do the exercise again, so you have the left aortic knob, you have a left apex and a left stomach, which is good. You have a big heart, mainly the left ventricle, and you have a left lower lobe atelectasis with hyperinflation. And that baby was clearly clinically and on the radiographic x-ray in heart failure. On the heart ultrasound, it was an Al-Kappa, which is an abnormal branching of the main left coronary artery from the pulmonary artery, which necessitated a rapid surgery, and then the baby went well. Okay, it's an old cliche, but you can still see here that it's a newborn term baby with a huge heart, which all the chambers of the heart looks big. The vascularization is still low because it's a newborn, and in the first 24 hours, the pulmonary resistance are high. So usually, even though you can maybe later in life have increased vascularization, usually when the baby is just born, it's hard to see. In that particular case, so you see that the big heart on the chest X-ray, which was a cerebral AV fistula, Galen vein malformation. So not every big heart is from the heart. It's another case of a 16-year-old boy, quite in shape, soccer player, that came to the emergency room mainly for chest pain. He was leaning forward, super painful, and a bit of a hard time breathing. So the chest X-ray coming in the emergency room, so you see that big heart which is very dense. You see that the stomach is displaced inferiorly. You see that your carina is splitted, and you see here that the heart shape looks really big. So they call an urgent cardiac echo, and they had a hard time seeing the heart. So in that particular case, it was a pericardial tumor, which came to be a synovial sarcoma, and it was basically taking all the places in the mediastinum and shifted the heart superiorly that was sitting on the heart. And the kid didn't do well. He died like a year after. It's not good things to have. So if you have a big heart on plain films, what can it be? So it can be non-cardiac, like anemia. You see usually our patient with falciform anemia, that sickle cell anemia have big lungs because of the anemia from a long day. You can have metabolic disorders or AV fistula or hypervascular tumors in little kids that can do like this, like hemangioendothelioma. And then it can be cardiac. So from every congenital heart cardiac disease that can do that, you can have cardiomyopathy, rhythm troubles, myocarditis, and you can have tumors. And you can have false big hearts like thymus and mediastinal masses. Okay, so we have a 2-month-old baby, which is tachypnic, with a normal, nearly normal saturation. Let's say it's not cyanotic. So what do we have here? So you have a heart that is quite big. You have a left aortic knob, you have a left apex, you have a left stomach, which is okay. So next thing, the vascularization. So how is the vascularization of the baby? When I talk vascularization, I talk the pulmonary arteries of the babies. So here you have big pulmonary arteries. So the lung vascularization is increased with a non-cyanotic baby. Looks like a shunt. So this is an example of a shunt vascularization with a big heart and large arterial vessels, which in that case was a large VSD. You have another case of a 2-month-old baby coming for failure to thrive, and he had a VSD, a large VSD. So what do we see here? So you have hyperinflation of the lung, slight cardiomegaly, but not that much, and you have that increased arterial vessels, which was secondary to the shunt, the left to right shunt, secondary to the VSD. We have another case. It's an 8-month-old baby, so recently adopted, no history. So you have here the chest X-ray that you can see that there's slight hyperinflation, heart looks a bit big, and here you see those rounds here. So those are all pulmonary arteries that are big. So in that case, it was a patient with trisomy 21 with endocardial Cushing defect that was not operated or addressed because when he was born in a country that has almost no health system. So here you see that the vascularization is big, and you see that he has a hypersegmented sternum, which is a sign of trisomy 21. So it's another example with a kid with trisomy 21 and endocardial Cushing defect that give a large left to right shunt. So you have a big heart, big pulmonary arteries, and an hypersegmented sternum. So what to check for the signs of trisomy 21 on chest x-ray? So you can have 11 or 13 pair of ribs. You can have an hypersegmented sternum, more than 6 ossification centers. You can have a bifid meningibrium. You cannot see that much on the x-ray. And you have that squared right heart border here that you can see in patients with trisomy 21, even though they don't have any endocardial Cushing defect. I don't know why, but you have that right squared heart you can see. Okay, so what do we do with a baby that has increased arterial lung vascularization, so big pulmonary arteries, and no cyanosis? So it's basically a shunt. So it's a left to heart shunt. So what it comes from? It can come from the intracardiac or extracardiac. So if you have an extracardiac left to right shunt, you have an AV fistula, hemangioendothelioma, or anemia. And it's an intracardiac shunt. It can basically be from a VSD, a ductus arteriosus, an ESD, and a cardiac Cushing defect, or partial pulmonary artery, partial abnormal pulmonary venous return, So in young babies, what can decompensate a baby with an endocardial shunt? It's basically the VSDs and the endocardial Cushing defects that can cause them to decompensate. The premature baby can decompensate on the ductus arteriosus, but usually on a term baby, like a 2-3 month old, usually they decompensate on the VSD and endocardial Cushing defect, because usually at that time of age, even though they have a slight ductus arteriosus, it's usually not a big thing. So what they will do, they can present with pneumonia, atelectasis, and failure to thrive. Okay, so what do a shunt cardiopathy on the chest? So first, you have an increased arterial supply, so more blood flow to the pulmonary artery because of the left to right shunt. So to see it in the chest x-ray, you have to have a shunt more than 2-for-1, so 2 times more pulmonary flow than the systemic flow. The consequence of that is you have the pulmonary artery that looks big, and then you can have a big heart. From that thing, you can end up with a left heart failure, which can give you interstitial edema or alveolar edema, but basically in babies, your first manifestation of left heart failure is lung hyperinflation. And then you can have a manifestation on the lungs, which can give you atelectasis and pneumonia. Okay, so in that case, you have a little baby. It's a 1-week-old baby already in the ICU or in the NICU with already have a PICC line. He's cyanotic, so it's a blue baby. So what do we have? So you have your aortic nog on the left, pulmonary heart apex on the left, stomach on the left, so it's good. The heart is big. It's not small, it's big. And if you check the pulmonary arteries, they look huge. So you have an increased lung vascularization in that case. So big heart, increased lung vascularization, left aortic arch. Is it an egg on a string? I'm not sure. But in that case, it was transposition of the great vessels. So this is the most beautiful egg on a string I saw in my career. It was a baby that was already had 2 months old, and he was basically living on a VSD, because usually those little babies, they don't do it really well at when they're born. They need the prostaglandins and usually a Rashkin procedure to open the ASD. But that kid had a VSD, so he was able to live longer without any intervention. So you see that the mediastinum is small. The thymus has shrinked, and because of the way the great vessels are positioned, your mediastinum is small, and then you have the egg on a string form with the DTGA. So you have a little baby which is tachypneic and cyanotic too. So what do we see? In that case, the aortic knob is on the left, pulmonary heart apex on the left, and then you have the left stomach bubble on the left. So you're okay. And then the heart, is it big? Yes, the heart is big. You have a huge hyperinflation. And here too you have increased pulmonary artery supply. So you have increased lung vascularization. So everything's on the left. The size is big. Is it any sign of failure? Yes. And in that particular case, you cannot tell that on the chest X-ray. It was a pulmonary atresia with tricuspid regurgitation. Okay, we have another case of a baby that basically looked like the first one we had. So you have cyanotic baby. So apex is on the left, aortic arch on the left, stomach on the left, you're okay. The heart is big, but the lung vascularization is low. So you don't have much vessel, you see almost not. So it's not an increased lung vascularization. So the most common diagnosis in a big heart with decreased lung vascularization is Epstein's disease. The differential diagnosis would be the pulmonary atresia with an intact septum, but the most common is the Epstein disease. So the classic shape of the Epstein disease is a box-shaped heart, which looks like a big thing with not much vascularization. So it's another baby that the tube is not well placed, should be retired. So you have a aortic knob on the left, you have apex on the left, stomach on the left, pulmonary vascularization, probably normal or slightly decreased, but clearly not increased, and a big heart. In that case, it was a pulmonary atresia with intact septum. I'm sorry, just take a... So in that case, you have a 2-month-old baby with a cyanosis. So it was probably saturating around 75-80%. So what do we have? So you have a left aortic knob, left apex, left stomach is good. Heart is not big, so it's a small or regular size heart. And the pulmonary vascularization is not huge, so you don't have big arteries. It's clearly probably normal, slightly decreased lung vascularization. So the situs is normal, decrease or normal lung vascularization. And you have that little upward apex here, which means that you have right ventricular hypertrophy. And the most common diagnosis in that case is a tetralogy of Fallot. So this is a classic finding in a tetralogy of Fallot. So what do we see? We see a decreased lung vascularization. Usually it's normal, but in that particular case it was decreased. The boot-shaped heart. So you have the main pulmonary concavity, so not a big pulmonary artery. And you have 25% of tetralogy of Fallot can have an aortic arch, a right aortic arch. So you see that there's no much vascularization, and you see that boot-shaped heart. Okay, you have another baby here. It's a 1-week-old, which is cyanotic. What do you see? So you have a right aortic arch. You have a left apex, a left stomach, but the right arch. The heart is huge or normal. And here it's a bit subtle, but the vascularization was slightly increased. So right arch, big heart vascularization, not clear. In that particular case, it was a truncus arteriosus, because 35% of truncus arteriosus can have a right pulmonary arch. Okay, so you have a 3-year-old baby, which is cyanotic, saturating at 83%. So what can we see? So aortic arch probably there, apex, stomach, okay. The heart is not that big, but the vascularization is huge. So you have an increased lung vascularization. And what do you see here? So you have that upper mediastinum that is large, that you can still see in the anterior here on the lateral view. So what do we have? So you have the increased lung vascularization, you have the large upper mediastinum, you have this, it's a snowman-shaped heart, which is a classic of a supracardiac total abnormal pulmonary venous return. So you have your snowman here. So the snowman represent all of the 4 pulmonary veins that instead of coming towards you in the left, atrium, it goes from a vertical vein directly to the left innominate vein and then back in the superior venic cava, which makes the head of the snowman. Okay, so you have a blue baby. What do you check first? If you have a blue baby, you check vascularization. If your vascularization is increased, it means that you have a right to left shunt, so you have a mixing. And those cases, you see your 5 T's. So DTGA, truncus arteriosus, total abnormal pulmonary venous return. You can have a tricuspid atresia, and the last T is like single or tingle ventricle. So cyanosis, increased vascularization, your 5 T's. If you're cyanotic and the vascularization is decreased, then what do we check? You see if the heart is big or not. So decreased vascularization with a small heart, it's a tetralogy of Fallot. Less commonly at tricuspid atresia, you see that depending on the ASD, you can have it in both lines. And if you have a big heart, it's an Epstein. The differential diagnosis would be a pulmonary atresia with the intact septum. So when the vascularization is not big, check the heart. Big heart, Epstein, small heart, tetralogy of Fallot. I think in my presentation, this is the most important figure, and I have to give the credit to my colleague, Dr. Lapierre. Okay. We have another case of a term newborn baby that is not going well, hard time saturating it, maximum ventilation. What do we see? So, so you see that the heart is not that big. You see that you have almost white lungs with looks like edema or fluid everywhere in the lungs, maybe a small pulmonary effusion on the right side, but not that much, so looks like a big edema. And then you have another baby, same pathology, a bit less severe, so a small lung, and basically huge edema on both sides with slight hyperinflation and a term baby. So both cases are the same diagnosis. So what do we see? Bilateral increased lung volumes, interstitial edema, worse in the first case, and then a normal heart size, which a normal arterial blood flow, so you cannot see like big pulmonary arteries, so it's basically an edema thing. In those 2 cases, it was infracardiac TAPVR, so it's total pulmonary venous return with blood flow that was coming in that case. It can go a bit everywhere, but usually the infracardiac are stenotic, and they can lead to pulmonary edema. This is important to have the diagnosis because usually those babies has to be operated really soon because the prostaglandin that they give them doesn't work for that, so they have to relieve the obstruction. This is the difference between those two cases, which big hearts and term babies. In those preterm little babies, which you have those small lungs and they look like pulmonary edema, which you can have in pulmonary distress syndrome of the newborn, which was formerly known as the AL and the membrane disease. So basically, it's the term of the baby, which are preterm, and the small lungs. So interstitial edema, what do you look like? What do you look for? If you have interstitial edema, you look for the heart size. So if you have a normal heart size, it can be cardiac, like an obstructive TAPVR, like we saw. And you have those two other things, like a cor triatriatum, which is a membrane in the left atrium that can be stenotic and increase the pulmonary resistance and creates an edema because the flow that comes through the left atrium cannot go in the left ventricle. It gets stuck because of the membrane here. And you can have pulmonary stenosis, either congenital or post-operative. You can have pulmonary edema, like the island membrane disease or an ARDS. And if you have a cardiomegaly, basically every cardiomegaly that we saw can lead to interstitial edema at a point, or you can have a mitral or aortic valvular disease. It's a newborn with pulmonary distress. So what can we see? You see that everything's on the left, which is a good thing. The heart is not that big, but you see those opacities, and it's hard to tell, is it pulmonary or is it big arteries? So the situs is normal, the vascularization is increased, there's hyperinflation in the small heart. The differential diagnosis would be a venous problem, so is there anything blocking the veins? And it can be a neonatal pneumonia like a chlamydia, but in that particular case it was an obstructive cor triatriatum, but you cannot tell that on the X-ray. So what's a cor triatriatum? So you see here on an MR, you see the mitral valve and you see the left atrium, and there's a membrane inside it. So you can see that when your pulmonary veins come here, they have an obstruction coming to the left ventricle, so you have edema. And here too, you have your mitral valve here, and you have that cor triatrial, which is that membrane here that divides the left atrium in two. So you have a kid. She was at that time probably a year. She already had been operated, so you can see here that she has a left wire that was left there. So what do you see? You see a huge hyperinflation. You see that the heart is small, and you see that you probably have some edema, maybe a thickened small fissures, no pulmonary effusion. So in that particular case, it was edema because of pulmonary vein stenosis. So you have a kid that was already operated for a total pulmonary abnormal venous return, and she had a stenotic post-surgery stenotic veins, which was why she was in edema, and they operated her, and she was good after that. Okay. It's a 9-month-old baby coming to the emergency room for a chronic cough. So what do you see? So you see that the apex is on the left, the stomach is on the left. But here, you see that your trachea, instead of shifting to the right side, is shifting to the left side. Usually in little babies, you don't really see the aortic knob. It's a bit hard to see, but you trust your trachea to tell you where is the aortic knob. So usually your trachea should be shifted on the right, and here your trachea is shifted on the left, so you can tell that there's a right aortic arch here. On the lateral X-ray, usually your trachea would be very, very straight. And in the case of a right aortic arch with a vascular ring, you can have an anterior displacement of your trachea on your lateral chest X-ray. So you have a right aortic arch with an anterior deviation of the trachea. Here you have the right aortic arch, and here you have the little anterior deviation of the trachea. In that particular case, it was a right aortic arch with cameral diverticulum. The most common of your vascular rings would be the diverticulum with abnormal left subclavian artery. So here is another example of a right aortic arch. So you see here that you have your trachea that is deviated on the right for the right aortic arch. And here you see that your trachea is deviated anteriorly because of the vascular ring. On a barium swallow, you will see that the abnormal vessel of the vascular ring will make an impression on the esophagus behind the esophagus. So it's not a talk about the vascular rings, because I can talk an hour just on the vascular rings. But if you want to read or, let's say, understand the vascular rings, you have to learn the hypothetical Edward rings that when you have learned that, you know all that has to be known for the vascular rings. So just to say that it's an hypothetical arch that you see that you have two arches, like an embryo. When you're an embryo, you have two arches, and depending where it cuts, it can explain almost all the vascular rings. Okay, here you have a kid always in respiratory distress. Hard to tell why. The couple of x-rays that we don't see nothing, but when we revise all the x-rays, we see that the trachea looks super small on every x-ray that we have. So here you see that the trachea is almost not seen, but it was just not a technical thing because all the other x-rays before was like this. And here on the lateral view, you see that the trachea looks really, really small. So in that case, it was a pulmonary sling. So what is a pulmonary sling? A pulmonary sling is the left pulmonary artery coming from the right pulmonary artery, passing in between the trachea in the esophagus, and can be associated with tracheal rings. So here you have the same case. Here you have the trachea, and you have tracheal rings that make tracheal stenosis, and afterwards the main bronchus that was normal. So on your barium swallow, that would be the only pathology that would make you a print on the anterior surface of your esophagus. So here it's your regular vascular ring, and here it's your pulmonary sling. So right arch. So if you see only a right arch, check the trachea. Is it deviated anteriorly? If it's deviated anteriorly, you can suspect a vascular ring, which is associated with congenital heart disease, and not that much, but 12%. If you see abnormal situs, let's say your stomach is on the right, look for an situs ambiguous, which is really super connected to congenital heart disease. And if you have a right aortic arch with an abnormal lung vascularization, you can be clearly sure that there's a congenital heart disease. So if you have a right aortic arch with an abnormal vascularization, if it's an increased vascularization, like I told you before, the most common is the truncus and arteriosus, because 35% of truncus arteriosus have a right arch, and some VSDs. You have a decreased vascularization. You can think of a tetralogy of Fallot. It would be the thing that you will see the most, because tetralogy of Fallot is way, way, way more frequent than the truncus arteriosus. And you can have pulmonary atresia. If you have a differential vascularization of the lungs, let's say one side is increased, one side is not increased, you can think of a PA that came from the aorta, which is rare. Okay, you have another case of a kid presenting for high blood pressure. So what can you see? Basically, you see that there's no issues with the aortic knob, let's say not on the side, apex on the left, stomach on the left, heart size is okay, lung vascularization looks normal. So what do you see? So what you see here is that little bump here, which looks like a tree, the number 3, which is a aortic coarctation that you see on the X-ray. It's rare to see them, but sometimes you see that little bump, which looks like a 3, which is the aortic coarctation. In that particular case, which is a different case, we see here on the lower part of the ribs. So you see the rib notching, which is really, really rare to see. You have to have a coarctation from a long time because there's so much collateral arteries that you can have the rib notching, but usually in little kids or babies that are diagnosed super early, you don't see that. In that particular case, it was a middle aortic syndrome from another part of the world. He was 12 years old and was basically living on almost no thoracic artery since he was a baby, so that's why we had rib notching. Okay, it was I'm sorry, I talk fast, and my English is not good this morning. So thank you. It was like a little, let's say, wrap of the pulmonary manifestation of congenital heart disease in kids.